Hello, everyone. My name is Camila Pimentel, and today we will talk about Patau syndrome or trisomy 13, but digestible. Let's begin. What is it? Patau syndrome occurs when chromosome 13 has an extra copy of the chromosome, making it a trisomy, but can also arise from an unbalanced translocation and mosaicism. To understand this better, see our video on Introduction to Chromosomal Abnormalities. Epidemiology happens in 1 per 5,000 total births, but only 1 in 20,000 live births. This means that most of them are stillborns. Of those born alive, 90% die within the first month, while only about 5% live longer than 1 year. Phenotype, or what can be seen. The main anomalies in trisomy 13 are intellectual disability, holoprosencephaly, when the brain fails to divide into two halves, and congenital heart defects, deafness, cleft lip and palate, and ocular defects. Karyotype, or what is encoded. The cause of Patau syndrome is the presence of three copies of chromosome 13, with a karyotype of 47XY plus 13 or 47XX plus 13. This one, look at my cursor, is the 13 chromosome, and the cause of Patau syndrome when it's triple. This most commonly happens due to non-disjunction in meiosis. This is an example of meiosis occurring more frequently in mothers over the age of 35. It can also present as a Robertsonian translocation. A Robertsonian translocation looks like this. It occurs when the short arms of the chromosome get deleted and the long arms become a long single chromosome, which results in two normal copies with an additional long arm of chromosome 13. Another way of representation for Patau syndrome is mosaicism, where three copies of chromosome 13 occur only in some cells alongside other normal cells. In this example, the left side has three copies of chromosome 13, and the right side has two copies of chromosome 13, having a normal karyotype. Manifestations. So, before we talk about manifestations, I'll talk a bit about the normal embryology. Patau syndrome is most known for its midline defects. What is the midline? The midline is the imaginary line that divides the body from left to right. There are structures that are embryologically are one but divide into two, like the brain. There are also structures that embryologically are two and merge together, like the palate and the lips. Keep this in mind when I talk about clinical manifestations, especially in the head. Face. Facial defects are primarily midline and include cyclopia, which is one eye, we can see it here, cleft lip and cleft palate, which is when the lips and palate fail to fuse. Fa- Facial features include a sloping forehead, small malformed ears, and preauricular preauricular tags, and also they can have microcephaly, which is not shown here. Microcephaly is when they have an abnormally small head. Continuing with face, they can have anophthalmia, which is the absence of eyes. They can have microphthalmia, which is when the eyes are very small. They can also have a coloboma, which is um, the iris, the retina, and or the eyelid fail to develop correctly, and most commonly it manifests as a groove extending from the pupil instead of a round iris. And finally, for the face, they may have micrognathia, which is a small jaw. Central nervous system. The central nervous system abnormalities are also normally midline, with a lower holoprosencephaly being the most common defect. This is the one. Holoprosencephaly is when the forebrain fails to divide into two hemispheres. It can be lobar, semilobar, and allobar. Lobar is when there are two ventricles, right and left, but the cerebral hemispheres are fused in the frontal cortex in this part. This is the least severe form of holoprosencephaly. Semilobar, it happens when the left side of the brain is fused to the right side in the areas of the brain known as the frontal and parietal lobes. Allobar, this type means the fetal brain hasn't developed into two hemispheres at all. It's usually associated with severe facial deformities. Babies with this type of holoprosencephaly are often stillborn or die shortly after birth. Remember, allobar is the one commonly presented in trisomy 13. Musculoskeletal. They can have intrauterine growth restriction, which is a smaller baby for gestational age, and common extremity defects include post-axial polydactyly, which is on the, for example, if it's your right hand, the right finger, the finger on the right is going to be duplicated. If it's your left foot, the small toe on the left is going to be duplicated. So it's on the sides, on the outermost sides that is duplicated. It can also have congenital talipes equinovarus, which is also called a clubfoot. It's a condition present at birth where a baby's foot is twisted or rotated inward and downward. Or they can also have rocker bottom feet, which is this one, which is a deformity where the foot has a convexly rounded sole, making it look like the sole of a rocking chair. So, normally, the foot has a shape that looks like a heel. You have the clear heel, and then you have an arch, and then you have the rest of the foot. But in this case, the arch is inverted. Cardiovascular. Let's explain how the heart normally works before I explain the pathologies. Look at my cursor. The deoxygenated blood gathers into the right atrium through the superior and inferior vena cava. Then it passes to the right ventricle. The right side is in blue. Afterwards, it passes through the pulmonary arteries to the lungs, where it becomes oxygenated. Later, it comes back to the heart through the pulmonary veins, which connect to the left atrium. And from the left atrium, remember the left side is represented in red because this blood has more oxygen. It passes to the left ventricle, which tends to have thicker muscles because it sends the blood to the systemic circulation. From the left ventricle, the blood is pushed to the aorta, which is the red arch, to the rest of the body. So the right side has weaker muscles because it only sends to the lungs. The left side sends to the rest of the body, so it has thicker muscles.
Since we know now how the heart normally works, let's talk about congenital heart diseases these babies face. So, first of all, we have ventricular septal defect, which is when there is a hole here in the septum of the ventricles. They can also have an atrial septal defect when there is a hole between the atriums. There is also tetralogy of Fallot. Tetralogy of Fallot is a disorder that has four concomitant heart defects, which is a ventricular septal defect, which causes a shunt from left to right. And overriding aorta, the aorta will be about here and it will carry mixed blood. They will also have pulmonary stenosis. The pulmonary um, valve is going to be rigid. And then this ventricle, the right ventricle, will have hypertrophy. So the walls are going to become thicker for two reasons. One, because it's also working to push the blood to the systemic circulation through the aorta, since the aorta is going to be about in the middle. And two, because these valves are rigid, they need to push harder to get the blood across to the to the pulmonary circulation. They can also have an atrioventricular septal defect, which is when these four chambers, the two atriums and the two ventricles, are connected. This causes the blood to get mixed. When I say blood mixed, I mean the deoxygenated blood with the oxygenated blood. This can also cause pulmonary hypertension because the left ventricle is going to be sending blood to the pulmonary arteries as well. Double outlet right ventricle. Sorry. This is when we have the aorta on the right ventricle. In babies with this pathology, they must have a ventricular septal defect to survive because this hole here will enable the oxygenated blood to mix with the deoxygenated blood to send to the systemic circulation because the aorta is on this side. If there is no hole on this side, then the aorta will only send deoxygenated blood to the rest of the body, and the blood from the pulmonary veins is not going anywhere. That's why we need the ventricular septal defect to survive. This is in double outlet right ventricle. Neurocognitive and psychological. Patients surviving past infancy have a severe psychomotor disorder, failure to thrive, intellectual disability, and seizures. Others. Additional organ systems affected by abnormalities include the lungs, the liver, kidneys, genitourinary tract, digestive tract, and pancreas. Defects in these organs that occur in greater than 50% of patients with Patau syndrome include cryptorchidism, which is when the testes fail to descend from the abdomen, hypospadias, which is when the urethral opening is on the ventral part of the penis instead of the tip, and labia minora hypoplasia, which is when the labia minora is smaller than normal. Epicorneate uterus is when the two sides of the uterus fail to fully merge, so you have a uterus like that looks like two horns. Abnormalities in these organ systems occurring in less than 50% of patients with Patau syndrome include omphalocele, which is when the organs from the abdomen are outside of the body, an incomplete rotation of the colon, a mechal diverticulum, a polycystic kidney, which is when the kidney has a lot of cysts, hydronephrosis, which is when the kidneys swell up with water, horseshoe kidney, when the two kidneys are merged together in a horseshoe shape. Diagnosis. It is done prenatally with lab testing of karyotype using chorionic villus sampling or a placenta sample, which is another way to say it, amniocentesis, which is a amniotic liquid sample, or a fetal-free DNA in maternal blood analysis, which is the preferred method of diagnosis. They can also do a prenatal ultrasound, which at 17 weeks is most sensible and can also detect the malformations that are on Patau syndrome. It's good to know that some of these malformations may be present in other syndromes. So the malformations are holoprosencephaly and other central nervous system anomalies, facial anomalies, skeletal abnormalities, renal and cardiac defects, and growth restrictions. These are the anomalies that are typically present. Treatment. Intensive treatment of Patau syndrome is controversial due to the universally poor prognosis of patients despite treatment. At delivery, infants diagnosed with Patau syndrome may need post-delivery oxygenation and ventilation. This may require intubation or tracheostomy due to facial defects. Patients with cardiac defects may require cardiac surgery to repair common cardiac abnormalities. Other surgeries may be indicated for common defects: herniorrhaphy, which is hernia repair, cleft lip repair, feeding tube placement, corrective orthopedic surgeries. Additional treatments may be performed, including specialized dietary feeds, seizure prophylaxis, prophylactic antibiotics for urinary tract infections, and the use of hearing aids. Prognosis. Median survival is 7 to 10 days in live-born patients, and 90% live for less than 1 year. Prognosis is better in patients with mosaic Patau syndrome and patients with unbalanced translocation. Aggressive management with surgical and medical intervention may extend median survival to 733 days. If you are a parent with a baby on the way or that has been born with this chromosomal variant, I want to tell you that it's not your fault. Patau syndrome is a spontaneous chromosomal occurrence, and nothing can be done to prevent it 100%. What matters is that whether in the womb, in the crib, or in the grave, this is your child and no one can take that from you. It is also not uncommon for parents to terminate pregnancies where fetuses are impacted with this syndrome. No matter what choice you make, I recommend therapy for parents that are carers or have suffered a loss, and my heart goes to all of you. Although these patients tend to have a brief existence, remember a diagnosis is not the end of the world, but the start of a new one. And even if they can't make it to term, they feel the love that you give them. A big hug from my part. I want to give a shout out to the sources. So we have Cleveland Clinic, Holoprosencephaly, and also the online book Stud Pearls Patau Syndrome by Grant Williams. This chapter is by Grant Williams. We also have the book Langman's Medical Embryology 15th edition. And the credits: Camila Pimentel, drawings, editing, script, voiceover, Jess Bell, credit the editor, Joanna Strange, humanitarian approach, my family and dogs for moral support, and finally you that's watching this video, thank you very much for making it to this point. If it's not too much to ask, please subscribe, leave a like, and a comment. Thank you very much.